Latex allergy. Latex is derived from the sap of Hevea brasiliensis rubber tree. Hev-B proteins within latex act as the major allergens. Latex, although previously commonly found in much anesthetic and surgical equipment, has significantly lessened with the awareness of the prevalence of latex allergy. However, this should not result in complacency in preventing such reactions. Classification of reaction: irritant contact dermatitis, non-allergic, irritant contact dermatitis, presenting over minutes to hours. Damage to skin due to exogenous substance causing irritation. Contact dermatitis type 4, delayed hypersensitivity reaction, based on allergic sensitization mediated by T lymphocytes. Presents over 48-72H with an eczematous eruption. This can progress to lichenification and scaling on chronic exposure. Type 1 hypersensitivity. Development of latex sensitivity is dependent on previous exposure. Immunoglobulin-mediated type 1 hypersensitivity has been attributed to Hevb proteins in latex. The three main presentations are contact urticaria, particularly of healthcare workers, typically 10-15 minutes following, and usually at the site of exposure. This may develop into a more severe reaction, asthma and rhinitis, characterized with bronchospasm and secretions. Inhalation of airborne latex particles from powdered gloves has been implicated. Anaphylaxis. This is more commonly encountered intraoperatively. IV and membrane inoculation are the commonest triggers. However, donning of gloves and indirect contact have also been described. High-risk individuals. 8% of the population are sensitized to latex. However, 1.4% of the population exhibit a latex allergy. Latex anaphylaxis appears to be more common in. There are certain groups at particular risk of developing latex sensitivity. Multiple surgical procedures. Patients with repeated exposure to latex have an high risk. Neural tube defects, including spina bifida. Incidence of latex sensitivity due to recurrent bladder catheterization is 20-65%. Associated medical conditions. Patients with atopy, asthma, rhinitis and severe dermatitis have an high incidence of sensitivity. Healthcare workers. Prevalence of sensitivity can be between 3% and 12%. Latex allergy. 1087. Occupation: rubber industry workers, occupations involving the use of protective equipment, policemen, hairdressers, service food workers. Fruit allergens. Patients allergic to fruit have an 11% risk of a latex reaction. Cross-reactivity has been demonstrated with certain fruit allergens: banana, chestnut, avocado, passion fruit, tomato, grape, celery, peach, watermelon, cherry and kiwi fruit. Prevention of latex anaphylaxis. All team members need to be alerted if a patient has a latex allergy. The operating theater should be prepared the night before, as this reduces the number of latex particles in the air. The patient should be scheduled first on the list. Latex allergy notices should be placed on theater doors. Only use latex-free equipment. Remove non-essential equipment from the vicinity of the patient. Limit staff traffic during surgery. Resuscitation equipment must be latex-free. There is no evidence to support prophylactic use of antihistamines and corticosteroids. Clinical features of latex anaphylaxis: onset is normally 20-60 minutes following exposure and progressively worsens over 5-10 minutes. Treat as for anaphylaxis. Further reading: Lieberman P. Arterial injection. Historically, barbiturates and benzodiazepines. Condition: unintentional intraarterial injection of medication can cause paresthesia, pain, motor dysfunction, compartment syndrome, gangrene and limb loss. Presentation: intense burning pain on injection, distal blanching, blistering. Immediate action: stop injection, label cannula, flush with 0.9% sodium chloride and maintain tissue perfusion. Follow up action: anticoagulation and specialist referral investigations. APTT also consider extravasation, dilution, error of drug administered intraarterial injection. Historically, barbiturates and benzodiazepines have been implicated in many of the inadvertent intraarterial injections, but many drugs, including antihistamines and antibiotics, have resulted in serious harm. Risk factors: arterial line in situ for BP monitoring, multiple ports for IV and arterial lines, cannulae placed under difficult circumstances, hypotensive, obese patients, emergent situation, and not flushed. If in doubt, take a blood gas from the line. Proximity of the brachial artery makes antecubital fossa cannulae more prone, but also aberrant ulnar or radial arteries can be cannulated at the wrist. Stronger drug concentration. e.g., 5% thiopental. Pathophysiology, not well defined and may depend on medication but results in tissue ischemia distal to injection site. One proposed mechanism, chemical endarteritis characterized by arterial vasospasm, local release of noradrenaline. Crystal deposition within the distal arteries thiopental, subsequent thrombosis and distal ischemic necrosis. Diagnosis: intense burning pain on injection that may last for several hours, blanching of the skin and blistering, within 2h, edema, hyperesthesia, motor weakness, later, signs of arterial thrombosis plus or minus gangrene, necrosis. Condition: unintentional intraarterial injection of medication can cause paresthesia, pain, motor dysfunction, compartment syndrome, gangrene and limb loss. Presentation: intense burning pain on injection, distal blanching. Blistering. Immediate action: stop injection, label cannula, flush with 0.9% sodium chloride and maintain tissue perfusion. Follow up action: anticoagulation and specialist referral investigations. APTT also consider extravasation, dilution, error of drug administered intraarterial injection. 1089 Immediate management: empirical, aimed at maintaining distal perfusion and symptomatic relief. Stop injecting and keep the cannula in situ, labeled clearly, and place an IV cannula, if the drug administered was highly irritant. Flush the vessel with 0.9% sodium chloride or heparin eased 0.9% sodium chloride and then maintain cannula patency with slow infusion. Initiate anticoagulation with heparin and discuss with vascular surgeon. Administer LA via the cannula to reduce vasospasm and pain. Give analgesia. Administer a vasodilator e.g., papaverine 40 mg, through cannula or consider prostacycline analog, iloprist IV, once the immediate reaction has subsided. If the hand is well perfused and pink, remove the cannula and apply sufficient pressure to the puncture site to minimize local hematoma formation. Inform the patient of what has happened and document all actions clearly. Subsequent management: to reduce pain, consider a sympathetic blockade, via stellate ganglion or brachial plexus, or guanethidine block. Consult a chronic pain specialist. Anticoagulation with heparin to reduce the risk of late arterial thrombosis, reestablishment of blood flow to extremity if necessary, treat sequelae of tissue hypoperfusion, fasciotomy, amputation, skin graft. Rehabilitation and follow-up. 109 1090 Chapter 39 Anesthetic emergencies and complete reversal of neuromuscular blockade. See also pages 420-2 and page 425. NMBAs are routinely monitored prior to extubation. Reversal of NMBAs with neostigmine 50 micrograms kg, accompanied by glycopyrronic. Risk factors: recent dose of relaxant or drug administration. Condition: residual competitive antagonism at nicotinic acetylcholine receptor of neuromuscular junction. Presentation: uncoordinated, jerky movements during the recovery phase. Inability to maintain an airway. Inadequate minute ventilation. Action: maintain and protect airway, and provide adequate ventilation and reassurance. Maintain, reestablish anesthesia. If appropriate, reverse aminosteroids with Sugamidex. Investigations: PNS, TOF, DBS. Post-tetanic count. Also consider high volatile agent concentration. Hyperventilation at CO2 is less than 4 kPa, CO2 narcosis, at CO2 is greater than 9 kPa. Intracerebral event injury. Hypoglycemia. Incomplete reversal of neuromuscular blockade. 1091 DBS may be useful to appreciate small degrees of residual block versus the TOFR. Post-tetanic count is used to monitor deep relaxation when the TOF will not show any twitches. A 50 Hz tetanic stimulus is applied for 5s, followed by single stimuli at 1 Hz. Post-tetanic facilitation in the presence of non-depolarizing blockade allows a number of twitches to be seen. Reversal with an anticholinesterase should be possible with a count of 10. If no twitches, establish that the PNS is working. Immediate management, ABC, if patient still has an ET, assess depth of anesthesia, if contributing to hypoventilation, reduce, if patient awake and anxious, deepen. If ETCO2 is not normal, correct by adjusting ventilatory settings, consider pressure support ventilation. If the patient has been extubated, reassure them, consider a sedative. Open the airway, remove secretions and support ventilation with careful bag mask assistance. If neostigmine has been given, ensure it was the correct dose, 50 micrograms kg. and the cannula was flushed. If you have used an aminosteroid muscle relaxant, rocuronium, vecuronium and pancuronium, administer Sugammadex at a dose of 2-4 mg/kg if available. Hypothermia. Electrolyte imbalance and acidosis will impair reversal and should be corrected. Aminoglycoside or Mg2+ can interfere with reversal, which may improve with calcium gluconate, 10 ml of 10% IV titrated to effect. Subsequent management. Wait patiently. This is not an emergency. Explain to the patient what has happened. Apologize and arrange counseling, if required. Awareness is difficult to predict, and the use of the Bryce interview questionnaire may help in this scenario. Other considerations. A dual, phase 2, blockade occurs when large amounts of succinylcholine are used. Suspected myasthenia gravis should be confirmed postoperatively with an edrophonium test. Further reading: Lens A, Hill G, White PF. Emergency use of Sugammadex after failure of standard reversal drugs. Annes van Elk, 104, 58 5-6.1092-1092. Chapter 39. Anesthetic emergencies. Local anesthetic toxicity risk factors. Type of LA, short versus long-acting, ester versus amide. Prilocaine is an ester which is rapidly metabolized by the liver with less risk of LA toxicity. Intrinsic vasoconstrictive effects reduces systemic absorption and thus improves safety, e.g., ropivacaine. Formulation. Bupivacaine is a racemic mixture with the R enantiomer binding more firmly and released more slowly from the myocardium. Site of block: intercostal, central neuraxial brachial plexus SE, single versus infusion multiple dosing. Overall dose: conduct of block, not visualizing needle tip with ultrasound scanning, overly firm pressure with probe causing compression of veins preventing their identification, failure to aspirate causing inadvertent IV administration. Not using incremental dosing or test dose, performance on anesthetized patient rather than awake, comorbidities, cardiac failure susceptible to myocardial depressant, liver disease reduced metabolism, renal disease reduced clearance. High-risk groups, elderly, pediatric and pregnant. Presentation: lightheadedness, dizziness, drowsiness, tingling around the lips and fingers, or more generalized, metallic taste, tinnitus, blurred vision, confusion, restlessness, incoherent speech, tremors or twitching, leading to convulsions, with loss of consciousness and coma, bradycardia, hypotension, CVS collapse and respiratory arrest, ECG changes, prolongation of QRS and PR interval, AV block and/or changes in T-wave amplitude. Condition: excessive LA in systemic circulation. Presentation: excitatory CVS and neurological symptoms followed by CVS and neurological depression. Immediate action: stop LA administration, resuscitate and support, treat seizures. Lipid emulsion therapy. Follow-up action: ICU if CVS collapse. Awareness of pancreatitis as a potential complication of lipid emulsion. Investigations: ABG, ECG. Amylase or lipase. Also consider anaphylaxis, CVE, migraine. Other causes of cardiac arrest: 4Hs plus 4Ts. Local anesthetic toxicity. 1093. Immediate management: discontinue injection, call for help, ABC and administer 100 O2. Intubation may be required to prevent hypoxic CVS collapse. Hyperventilation may help by IPH and metabolic acidosis. CPR if pulseless. Commence the ALS protocol. Treat convulsions with IV. Midazolam 3-10 mg, diazepam 5-15 mg, lorazepam 0.1 mg/kg, propofol 20-60 mg, thiopental 50-150 mg. Lipid emulsion therapy, given IV bolus injection of 20% lipid emulsion, e.g., intralipid registered sign 20%, 1.5 ml/kg over 1 minute, 100 ml for a 70 kg patient. Start an IV of 20% lipid emulsion at 15 ml/kg h, 1000 ml over 1 h for a 70 kg patient. Repeat the initial bolus twice at 5 minutes intervals if inadequate circulation has not been restored. After 5 minutes, double the infusion rate if inadequate circulation has not been restored. Continue CPR. The ALS protocol and lipid infusion until a stable circulation has been restored. The mechanism of action is thought to be through extraction of lipophilic LAS from aqueous plasma and tissues or by counteracting LA inhibition of myocardial fatty acid oxidation, although other theories exist. Other considerations: propofol is not a suitable alternative to lipid emulsion. Resuscitation attempts can be prolonged due to prolonged protein binding of the offending LA. Methemoglobinemia may occur with high doses of Prilocaine, 600 mg in an adult, 2 degrees to the metabolite odoluidine. Treat with methylphenenium chloride, methylene blue 1-2 mg/kg. Allergic reactions to LAS are extremely rare. The ester groups are more prone to exhibit allergic reactions than amides, because they are metabolized to para-aminobenzoic acid PABA, which acts as a heptane. There is also a cross-sensitivity of ester-type agents with sulfonamides. Allergic reactions range from simple local irritation with rash or urticaria to laryngeal edema or anaphylaxis. Unanticipated difficult intubation, see Figure 39.5, see % pages 368-9. Plan A, face mask ventilation and tracheal intubation. Optimize head and neck position. Pre-oxygenate. Adequate neuromuscular blockade. Direct video laryngoscopy. Maximum 3+1 attempts. External laryngeal manipulation. Bougie. Remove cricoid force. Maintain oxygenation and anesthesia. Conrim tracheal intubation with capnography. Succeed if in difficulty. Call for help. Declare failed intubation. Plan B, maintaining oxygenation. SGA insertion. Second generation device. Recommended change device or size. Maximum 3 attempts. Oxygenate and ventilate options. Consider risks and benefits. 1. Wake the patient up. 2. Intubate trachea via the SGA. 3. Proceed without intubating the trachea. 4. Tracheostomy or cricothyroidotomy. Stop and think. Declare failed SGA ventilation. Wake the patient up if face mask ventilation impossible. Paralyze final attempt at face mask ventilation. Use 2-person technique and adjuncts. Plan C, face mask ventilation. Declare SECO. Plan D, emergency front of neck access. Scalpel cricothyroidotomy. Post operative care and follow up. Formulate immediate airway management plan. Monitor for complications. Complete airway alert form. Explain to the patient in person and in writing. Send written report to GP and local database. This outchart forms part of the DAS guidelines for unanticipated difficult intubation in adults 2015 and should be used in conjunction with the text. Figure 39.5. Unanticipated difficult intubation, see Figure 39.5, see % pages 368-9. Plan A, face mask ventilation and tracheal intubation. Optimize head and neck position. Pre-oxygenate. Adequate neuromuscular blockade. Direct video laryngoscopy. Maximum 3+1 attempts. External laryngeal manipulation. Bougie. Remove cricoid force. Maintain oxygenation and anesthesia. Conrim tracheal intubation with capnography. Succeed if in difficulty. Call for help. Declare failed intubation. Plan B, maintaining oxygenation. SGA insertion. Second generation device. Recommended change device or size. Maximum 3 attempts. Oxygenate and ventilate options. Consider risks and benefits. 1. Wake the patient up. 2. Intubate trachea via the SGA. 3. Proceed without intubating the trachea. 4. Tracheostomy or cricothyroidotomy. Stop and think. Declare failed SGA ventilation. Wake the patient up if face mask ventilation impossible. Paralyze final attempt at face mask ventilation. Use 2-person technique and adjuncts. Plan C, face mask ventilation. Declare SECO. Plan D, emergency front of neck access. Scalpel cricothyroidotomy. Post operative care and follow up. Formulate immediate airway management plan. Monitor for complications. Complete airway alert form. Explain to the patient in person and in writing. Send written report to GP and local database. This outchart forms part of the DAS guidelines for unanticipated difficult intubation in adults 2015 and should be used in conjunction with the text. Figure 39.5. Unanticipated difficult tracheal intubation. Can't intubate, can't oxygenate, see Figure 39.6, see % page 381, call for help. Plan D, emergency front of neck airway. Continue 100% O2. Declare SECO. Continue to give oxygen via upper airway. Ensure neuromuscular blockade. Position patient to extend neck. Scalpel cricothyroidotomy. 1. Scalpel, number 10 blade. 2. Bougie. 3. Tube, Q'd 6.0 mm ID equipment, laryngeal handshake to identify cricothyroid membrane. Palpable cricothyroid membrane. Impalpable cricothyroid membrane. Transverse stab incision through cricothyroid membrane. Thumb blade through 90. Sharp edge caudally, slide caudate tip of bougie along blade into trachea. Railroad lubricated 6.0 mm Q'd tracheal tube into trachea. Ventilate in a Q and conrum position with capnography. Secure tube. Make an 8-10 cm vertical skin incision. Caudad to cephalad use blunt dissection with injures of both hands to separate tissues, identify and stabilize the larynx. Proceed with technique for palpable cricothyroid membrane as above. Postoperative care and follow up. This outchert forms part of the DAS guidelines for unanticipated decollect intubation in adults 2015 and should be used in conjunction with the text. Postpone surgery unless immediately life-threatening. Urgent surgical review of cricothyroidotomy site. Document and follow up as in main flow chart. Figure 39.6. Can't intubate, can't oxygenate. Reproduced from Difficult Airway Society 2015 Guidelines for Management of Unanticipated Difficult Intubation in Adults. Difficult Airway Society Intubation Guidelines Working Group, BJA, 115, 6. 827-48 doi, 10.1093 BJA EVE 371. Permission for the use of these algorithms for commercial purposes must be sought directly from difficult malignant hyperthermia. See also condition life-threatening hypermetabolism in genetically susceptible patients triggered by volatile agents and succinylcholine presentation. DSPO2, IETCO2, IHR, I-core temperature, muscle rigidity, dysrhythmias. DIC immediate action stop volatile agents. Hyperventilate with high flow 100 O2 dantrolene 2.5 mg/kg. Cool follow-up action. Correct acidosis, IK plus and coagulopathy. Promote diuresis. Monitor for compartment syndrome investigations. ABGs, K plus. Clotting studies, CK. Also consider rebreathing CO2 absorption from pneumoperitoneum. Extended to tourniquet time. Pheochromocytoma. Neuroleptic malignant syndrome. Recreational drug toxicity, e.g., ecstasy. Thyroid storm. Malignant hyperthermia 1097 dantrolene. Give dantrolene 2.5 mg/kg. Select dose based on actual body weight to maximum 300 mg per dose. Repeat dose every 10 minutes until PaCO2 is less than 6 kPa and decreasing body temperature. No cumulative ceiling dose. Mortality associated with insufficient dosing. Activated charcoal filters, if available, place on inspiratory and expiratory limbs of the circle breathing system. Temperature, reduce temperature by exposing the patient, eyes to the groin and axillae, cold fluids and extracorporeal heat exchange if available. Monitoring, check ABGs and K+, and correct acidosis. Hyperkalemia. Subsequent management, place invasive monitoring arterial line and CVP line, send a clotting screen for DIC and serum CK assay, promote diuresis with fluids and mannitol. Monitor for AKI, avoid calcium channel blockers, treat arrhythmias with magnesium or amiodarone or metoprolol, will require HDU-ICU admission for at least 24h after resolution of metabolic derangement, monitor for recrudescence. Likelihood increases with increasing metabolic derangement during initial episode, monitor for rhabdomyolysis and compartment syndrome, refer to the MH investigation unit for follow-up. Other considerations, there are two formulations of dantrolene, Dantrium registered sign 20 mg, mixed with 60 ml of sterile water, and Ryanodex registered sign 250 mg, mixed with 5 ml of sterile water. Ryanodex registered sign is currently unavailable in Europe. A 100 kg adult requires 12 ampules of Dantrium registered sign per dose. The use of visual aids for task prioritization, such as prepared task cards allocating roles, improves team performance during an MH crisis. CM malignant hyperthermia or DO. Follow-up involves DNA testing for ryanodine receptor rare 1 mutations. If DNA negative, a muscle biopsy will be offered with in vitro halothane and caffeine contracture tests. Beware of using bicarbonate to correct acidosis if the acidosis is principally respiratory, since the reaction with H+ produces an ICO2 load. Anesthesia for known or suspected MH. Susceptible patients, MH patients should not be denied surgery solely because of MH. Preoperative questioning about personal and family anesthetic history is essential to identify potential MH patients. It is not essential to test suspected cases prior to surgery, provided individual assessment has been made of the risks involved. 1098 Chapter 39 Anesthetic Emergencies, an MH-safe technique, i.e. avoid succinylcholine and volatile agents, such as propofol or regional anesthesia, is appropriate. All other drugs are MH-safe. Dantrolene is not required prophylactically. It is unpleasant for the patient and prolongs the action of NDMRs. It should be available. Standard monitoring, i.e. ECG, NIBP, SpO2, ETCO2. A baseline core temperature should be established before the procedure and monitored for 4H post-operatively. The anesthetic machine must be purged and flushed to remove traces of volatile agents. In modern machines with complex internal silicon components, this can take at least 70 minutes, and then high FGF must be maintained throughout the case. A cost-effective alternative is the use of activated charcoal filters. These reduce machine preparation time to 2 minutes, e.g., VaporClean registered sign activated charcoal filters. Instructions for use of activated charcoal filters: remove vaporizers from the anesthetic machine, flush circuit for 90s with O2 or air at 10 Lmin using the ventilator with a 2L test lung attached, change the breathing circuit and soda lime while maintaining flushing at 10 Lmin. Use NuET and face masks. Insert activated charcoal filters on both the inspiratory and expiratory ports of the breathing system. 2 activated charcoal filters are used to remove the risk of incorrectly placing a single filter on the expiratory limb, which is ineffective. Maintain FGF of 10 Lmin for 90 minutes from the commencement of the anesthetic. After 90 minutes, it is safe to reduce FGF to 3 Lmin. Activated charcoal filters are single-use items and can be used at 3 Lmin for a total of 12 H.